Hi, everybody. I'm Katelyn Anderson. I want to say, I wonder if there's a button I need to press, maybe. Thank you. I want to say on behalf of myself, Dr. Bendel, and Dr. Polides, we're so thrilled to be here speaking with you today, and we're honored that we were asked by Mega and Melanie to present on this topic. So first of all, thank you for having us. And I think that Dr. Tollefson took the words right out of my mouth when saying that this is a difficult topic and one that can make physicians uncomfortable. And it is challenging for a number of reasons that we've already reviewed today. And I think that you are all very, very well aware of that. And I think one of the challenges in coming up with our talk is that we have a lot of examples that hopefully people here will identify with, which are just a small fraction of examples among the multitude of challenges that are faced by all of our patients in that transition from childhood to adulthood. And we don't have that many answers. So lots of short vignettes will be presented that we want to serve as a springboard for discussion with all of you. But we don't necessarily have answers or perfect solutions to every scenario. So it might be a little bit of a sad talk in that regard, but I think that it's one that's really important to have. So with that, we'll go ahead and get started. Indeed. And I just want to briefly acknowledge the patients whose clinical images are used for this talk, and we appreciate that. The objectives, so we'll review, as I mentioned, several scenarios that involve medical, meaning medicines used to treat, interventional and surgical management of vascular anomalies from childhood to adulthood. We'll be discussing some reproductive and hormonal considerations for patients with vascular anomalies, and then we'll consider some barriers to transitions of care that Dr. Sisk really already outlined quite nicely. So my portion of the talk will focus on medical management considerations from childhood to adulthood, again, kind of focusing on medicines that might be used and how things change going throughout your age. Patient 1 is a toddler with a very extensive vascular malformation and limb overgrowth. And patient 1 was started on sirolimus in infancy. Patient 1 has been doing very, very well, thriving on the medication without any issues, but now is 2 years old and missed an important vaccination, the measles, mumps, rubella vaccine that's typically given as part of the childhood vaccine series around the first birthday and then again before kindergarten. What to do with this kind of patient? So this is a scenario that we've encountered in clinic, and this is one of those that I don't have a great answer to. I think we can look to other specialties that deal with, that are familiar with or have expertise in children who are immunosuppressed to help us answer the question, but we don't have any great guidance for patients specific to vascular anomalies with this particular question. And even in the setting of, for instance, the pediatric transplant population, which is a population that often needs immunosuppression for life, we actually don't have a lot of great answers there either. One thing I want to bring up is timing. So timing of when we might start a medication like sirolimus, it sometimes is really critical. We have to start it right away. There's maybe some life-threatening event going on that requires a very early start without a lot of give or take in terms of, or flexibility in terms of when that can be. But for a lot of other patients, it's a discussion. It's something that's maybe been considered over multiple visits, and we can be somewhat elective in terms of when we decide to start that medication. And when we think about vaccinations, so there are two sets of vaccinations. There's live, and then there's attenuated, which are not made of or weakened or a particle from a virus or a bug and not made from the live. And those are fine to give, but the live vaccines are really contraindicated. So one thing to consider would be you could actually give MMRV early. You could give it at 6 months of age. It doesn't work quite as well, but it's still a possibility. So maybe this infant, or if you have somebody that is nearing that 6-month birthday, go ahead and get them vaccinated early. Start sirolimus 4 weeks after the vaccination. Another consideration is maybe they're doing really well and there's a period where they could transition off of sirolimus for a set interval of time with plans to go back on 4 weeks after vaccination. So we can discuss any of these scenarios and more in depth as we go, but again, just some ideas to stimulate discussion later. Patient 2 is an adolescent woman. She has PIK3CA-related overgrowth spectrum, and she is taking alpelisib. She during her appointment, expresses her wish to stop the medication. She said she is tired of frequent lab draws, medical appointments, constant reminders from parents to take her medication. She appears withdrawn during the appointment. I think this was also alluded to during Dr. Sisk's talk, that the psychosocial ramifications of having a chronic disease are really profound. And we need to also acknowledge that our adolescents are becoming adults. They need to have some agency and some decision-making into their own health and their own medicine process. So in this case, there's a couple things to be considered. One is kind of validating and acknowledging her feelings that this is really tough. This is not a normal adolescent existence. And maybe we do take a break. Maybe we say that, the benefits do not outweigh what this person is going through and how this is making her feel very different from her peers. And then the other thing to acknowledge is she going through depression or anxiety? Mood disorders are common in adolescents, and we know that mood disorders are even more common in those with a chronic medical condition. So we need to take that into account, not just be focusing on the alpelisib and the effect it's having in the lab results. Patient 3 is an adolescent man with lower extremity lymphatic malformation. Previously, he was having a lot of pain and swelling. He was placed on sirolimus. He's been on it for a couple months. He's improving. He's happy with the improvement he's noticing in his malformation. However, he says he would like to stop the medication. He has noticed acne. And again, the point of this one is acknowledging that adolescents also have normal adolescent concerns that really need to be validated. So they care about acne. Yes, they have a vascular malformation that might be life-threatening, but the acne really matters too. And sirolimus can cause acne or acne-like rash, so absolutely that might be a side effect of the medication. And in this case, maybe this is something where we refer him to a dermatologist, or we get him help for his acne and continue the sirolimus. Maybe we consider stopping it for the reason of the acne. Both would be very valid solutions in that case. Patient 4 is a 20-year-old woman taking trametinib, which is a MEK inhibitor type medication for a severe arteriovenous malformation of her hand. The medication is helping her as well, and she had been doing well on it for a number of years, but she went to college, finds her schedule to be extremely busy, and her coursework is suffering because she is expected to travel back and forth to appointments. So here's a situation, that young adult period of life where you're moving away from your parents' house, you're venturing out into the world, perhaps you're in some sort of trade school or college, and life has different demands, might be mental demands or physical demands, and that might affect a patient's ability to attend appointments, take medications, have lab draws. I think one thing here that the pandemic helped us with was accelerating our ability to do telemedicine visits. That's one thing we found to be helpful for our patients, is being able to offer phone or video consultation and still stay engaged with our patients who move or maybe are being treated from afar. Not to mention, many of our patients live from afar to begin with. So thanks to the pandemic, instead of taking what might have been a decade to get video visits going in telehealth, we are able to use that platform quite readily for our patients. Patient 5 is a 60-year-old man with diffuse lymphatic malformations. It's affecting his lung function. His team and our team agree that a trial of sirolimus would be a very appropriate treatment for him. However, he's already immunosuppressed. He has rheumatoid arthritis, and he is on a medication to treat that. He also has chronic kidney disease and anemia. So when Dr. Tollefson was mentioning that a lot of us are pediatric trained and we like to stay within a comfort zone, here's a case where, okay, healthy 10-year-old child with no other medications, great, let's start a medication, let's start sirolimus, let's start alpelisib. 60-year-old patient with multiple medical comorbidities and a long medication list, this is making us uncomfortable. We don't know how to manage these patients a lot of the time. And here's a situation where we're so lucky here to have a great support system, but we realize that's not like that everywhere. But picking up the phone, calling our specialists in rheumatology, calling the internist, explaining the situation, they may not be familiar with his lymphatic malformation, but they're very familiar with managing his other medical comorbidities. And we were safely able to start the medication, knowing that there's always some risk involved, but let's give this a try and let's work with his other physicians to make sure that we're doing it in the safest way possible. I would like to talk briefly about reproductive considerations. This is a huge topic that could probably fill multiple talks all in and of itself, but it's something that I think is very pertinent to transition from childhood to adulthood that many of our patients face. To illustrate that, our first patient is an adolescent woman. She's in a new relationship. She goes to her primary care and asks about starting a birth control pill. Her doctor looks uncomfortable and states that she believes the patient is not a candidate for the birth control pill due to her vascular anomalies. So here's the situation. I bet all of you in the room can think of a doctor that you've encountered who had never heard of Klippel-Trenaunay syndrome and didn't know what to do with it. And this is a scenario that we encounter a lot, that people wonder about options for birth control. And we can go into more in depth in the panel discussion if people are interested. But I think the short answer is there's not a one-size-fits-all. But absolutely, there are options for birth control for patients with Klippel-Trenaunay and other vascular anomalies that can be taken very safely. So again, we can talk more in detail as the panel goes on. Patient 7 is an adult woman. She is seen in vascular malformation clinic, and she's surprised to be asked if she's ever had any pregnancies. She states that she was told from a very young age that it would not be safe for her to carry a pregnancy to term or to deliver a baby. So again, a scenario that we've certainly encountered in clinic where there's a lot of information or misinformation out there, and there's a lot of physicians who have a discomfort with this condition or have never heard of it, and maybe have some misconceptions about what may or may not be possible. So again, this is very individual. Everybody's different and has a different spectrum of disease, but absolutely, patients with Klippel-Trenaunay syndrome can become pregnant and can have babies. And then depending on their specific anatomy and the location of their malformation, they may or may not be able to have, safely have a vaginal delivery. We might be able to help advise obstetrical teams on the safety of cesarean section and the particular location of their anomalies. And then, of course, advising the patient on what might happen during that pregnancy, perhaps more pain, swelling, discomfort in the affected limb, and considerations for things like taking a blood thinner to prevent blood clots are something that we take into account as well. But the short answer is that yes, it's certainly possible for women to become pregnant and have successful and safe pregnancies. Patient 8 is an adult man with his partner, and they are in clinic, and they state that they're ready to start a family, and he wonders if his vascular malformation can be passed on to his future children. We had a really wonderful genetics talk earlier that touched on a lot of aspects of genetics, including the fact that many of our patients, the majority of their mutation is somatic, meaning a somatic mosaic mutation, meaning that it would not be passed on to children. So that's something where in a case like this, we like to have all of our patients see a geneticist if it were possible, but in this case, really important to be able to have that counseling and maybe have testing to be a certain one way or the other about the risks. And then my final portion here before I pass it on to my colleagues is talking about barriers to transition of care. And my first study that I'm highlighting here is one that Dr. Sisk already highlighted, so I won't go into detail. But this was that survey of adult patients with vascular anomalies. And I think, again, without going over all the details all over again, the punchline of the study was that most patients, the vast majority, did not have a plan for transition to an adult specialist team, that they'd never. And then I think the other thing that I really wanted to highlight about this when I was reading it that really surprised me is when these were adult patients surveyed, but when they were looking back and reflecting back on their experience as a child, 62% report that they had little to no say in decision-making for the care of their vascular anomaly as a child. And so again, as our children age through their adolescent years and are able to participate in healthcare decisions, making sure that we are including them in that. And then one other study that I wanted to mention that came out relatively recently was a survey of providers within vascular anomaly centers, and this included Canada and the US. So in this case, there were 37 centers that answered the survey, and this really just highlighted the lack of access to transition of care programs. So only 6 of those 37 centers that answered the survey have an official transition of care program. In those 6 centers, transition of care started as early as 12 years of age. So this is a process that starts early and continues. It's not just a one and done, you come one day and the next day you're in an adult clinic. And then for those centers without an official transition of care process, most patients were transitioned abruptly at age 18. And then it should also be noted that only 8 centers surveyed continue care into adulthood. And we've talked about this with with many of you, and we've heard from you, and we heard from Dr. Sisks as well, that finding adult care is one of the most difficult challenges facing patients with Klippel-Trenaunay today. So in this study of providers surveyed, the reported barriers to transition of care included lack of resource, lack of insurance coverage, but the biggest one was difficulty finding specialists with expertise, which we've seen highlighted earlier. And then I think it's important to note that most of the provider survey did express concern. So it's not that they didn't want a transition of care program. They were concerned about their patients and wanted this for them. But really that lack of specialists with training was the biggest barrier. I think takeaways from these 2 studies, along with some other studies mentioned, and then, of course, from speaking with all of you and learning from you, are that patients with vascular anomalies need lifelong access to specialty medical care. Transitions of care program are vitally important and unfortunately very much lacking, and that there's difficulty finding specialists with knowledge and expertise, and that is probably the biggest barrier. I don't have a solution for all of this, but I would say that attending a patient advocacy meeting like this, learning from all of you what you need, and then hearing about the directions the research has going has given me a lot of hope. So with that, I'll wrap up my portion, turn it over to my colleagues, and I'm happy to answer questions about any of the medical topics that were covered earlier.
All right. Hi, I'm Emily Bendel. Recognize many of you. Thanks for having us speak today. All right. So as the radiologist, the token radiologist here, we're going to just do one patient scenario about imaging considerations. You can see here, this is a scanogram, and many of you in this room have probably had scanograms, and you probably realize that at some point somebody stopped getting them, right? I mean, we all stop growing eventually, at least taller. And then you start going the opposite direction, and people don't want to measure necessarily, the height of your knees anymore, your hips. And that's just one of the examples of transitions of care, right? So we have to remember those things for our pediatric and growing adolescent patients. And then in adulthood, we're kind of shifting some of that imaging focus to other things. So patient scenario number 9 would be a 16-year-old male. KT has new leg pain. It's been years since his last appointment. He's scheduled for an MRI. He's concerned that the last time he had an MRI was with anesthesia and is anxious about the MRI. So this just brings up the topic of, the options throughout the years change. When you're very young, a lot of people are going to use general anesthesia. And as you age, some of that may be carried forward, that expectation that you're going to go to sleep or not go to sleep. And that's just one of those things to have a conversation with your doctors. If there is a lot of anxiety about those tests, or if maybe one test, wasn't particularly great. One time I had a patient say, I was in there for 3 hours, and we don't know that you're in there for that long necessarily. And so giving that feedback loop and having those conversations with your longitudinal care providers to figure out how can we get the best test for you, the information we need without it being a miserable experience, or, how can we tailor some of these things for you and make sure we get the right test to answer the question to help guide therapy. So this applies to procedures as well. I do a lot of procedures, and, it is a conversation daily, this expectation of, how sedated will I be, or how much sedation does a person need for this type of procedure? Some of our sclerotherapy with bleomycin, we don't really need any, and some patients don't want sedation if they can avoid it. And for other things, we really need patient to hold still. We need that kind of control over a difficult procedure. So maybe general anesthesia is the most appropriate thing. But having those conversations, that patient advocacy, but also leaning on your physicians, your providers to help tell you what their experience has been with patients having this procedure done. So other procedural considerations. This is a patient that we've been seeing since we child, and then over the years was unable to use their extremity how they wanted, and eventually ended up having a hemipelvectomy and choosing amputation. This is just an example of what we're thinking over the years is, looking back, what would we have offered differently, or what would we have done differently, or maybe we wouldn't have done anything differently. How would they have chosen things? So moving forward into these patient scenarios for procedures, just keeping patients like this in mind. Just, now that we have some other tools, do we introduce those earlier, or do we still, just go based off of, the patient situation at that time? And a lot of it is we just don't have good evidence to guide us yet, but hopefully eventually we will. This is a patient of Dr. Barneson's that he shared with us because he has followed patients a lot longer than I have due to his experience. And this is somebody that he'd seen at the age of 6, venous malformation. You can see it right here in the left chest, and really had minimal symptoms at that time, no social concerns, and decided to kind of hold off on treatment. 7 years old, now developing some conscientiousness, a little discomfort, undergoes first round of sclerotherapy and has some improvement with that. Ages 9 and 10, more sclerotherapy sessions each year for discomfort as they become more active in sports, improvement with each sclerotherapy session, and the appearance as well improves. Here's an image from the sclerotherapy session in the venogram here. You see these puddled veins. Now at 14 years old, has had significant improvement after prior procedures, but going through puberty, developed increased symptoms, pain at rest, and exacerbated by sports, undergoes fourth sclerotherapy session. 16 years old, 2 more sclerotherapy sessions for similar pain with physical activity, does well for several years. Here's an MRI. You can see how deep the lesion goes, kind of getting back into these nerves of the arm. 20 years old. It's doing great since the prior procedures, but now comes in with left arm and nerve compression. So some new symptoms. Has sclerotherapy. Really isn't enough to get rid of those symptoms, so goes to an MRI guided ablation. That's where they put the probes in and they laser this area in an MRI scanner with the patient asleep. After that, phone call, patient's doing well since last procedure, no complaints. This is just an example kind of that ongoing conversation over the course of somebody's life and why it's so important to have adult care providers and to find somebody even in adulthood, because maybe it's not always the same answer. Sclerotherapy may have worked and met your needs when you were young, but later on, maybe something else. Or technology changes. We didn't have MRI guided ablation many years ago to offer, and now we do. So circling back with those care providers, see what has come up, what's evolved, and what's available now for your particular situation. Do you have anything to add to that? In terms of, I think, in some of those too, we're more apt to consider surgery now than we ever were before as well.
Yeah, we'll talk about a case subsequently, but I think there's more and more sort of hybrid options and multiple options, and we're starting to see now that we've had a chance to look at the natural history of multiple sclerotherapy treatments and even though one individual treatment may be less invasive than a bigger procedure, we can now give a little bit more guidance on, well, it may take several treatments of something less invasive versus one treatment of something a little bit more invasive, and just provide a little bit more of an option. And that's certainly, I think, as a patient or family, a very reasonable question to ask.
Yeah. So patient 11 here is another one talking kind of about that pregnancy aspect. 25-year-old female with KT, 20 weeks pregnant. Ever since 10 weeks of pregnancy, swelling legs, labia has been worsening. Has been trying to wear compression daily, but wonders about possible treatments during pregnancy or soon after delivery. And I get that a lot, like, how soon can I have this done? So here's our MRI. You can see the baby inside a very large uterus here. And you can also see really bright signal here in the labia. It's horrible labial veins. Unfortunately, we can't really do sclerotherapy with our chemical agents during pregnancy, but Doesn't mean you shouldn't talk to people if you're getting a lot of little clots. Maybe we talk about a blood thinner, or just, raising the question of, how else have other people handled this? So, just because we can't necessarily offer it right now doesn't mean we won't ever be able to. Generally, we wait a little while for all that fluid to come off after pregnancy. And then we talk about, when is the right time for you? A lot of people will be like, oh, my symptoms are gone, or they're better. I don't need anything now. But still making sure to kind of stay in touch in case you do need something, then we can have something planned. So this was a planned C-section. We were actually there for this patient in case there was bleeding, and there wasn't. So that was great. This is an image from the sclerotherapy after delivery in the months following, and she subsequently had multiple procedures for sclerotherapy, ovarian vein embolizations for vein issues. But
okay, and I'm just this is like, yeah, this is only on, but we can't.
So this was one that a 16-year-old with leg pain, incompetent great saphenous vein, undergoes mechanical and chemical ablation called Claravane of the great saphenous vein and sclerotherapy. Due to its superficial location and not wanting to burn the skin or damage the skin, the vein was occluded by ultrasound the next day. Patient returns 3 years later, is active, asymptomatic, and they're very diligent with compression. They felt the procedure helped, but when we look at the ultrasound, it does show it's open back up. And they do have some chronic changes in the vein. But now what do we do? Well, the patient was asymptomatic. In this case, they decided they didn't want to proceed with an intervention right now. But if they would become asymptomatic, maybe wanted to know their options. So we discussed that. Some of the considerations and what somebody brought up in a question to me yesterday via email was, what about the marginal or embryonic veins? What's the best treatment for those? And it really is individual to each patient. For some people, we do offer laser ablation, like an endoluminal, so inside the vein laser ablation. But if they start to get to be a bigger size, then we start looking towards surgery or coiling and gluing, which can be described in this paper. There's a lot of different techniques to shut down those veins, and it really is individualized. So we've also had questions about, have we seen anybody getting these procedures on patients that are taking these new medications, and are the results different? And I'm not aware of any studies right now because it's still in that new period of people being on them. But I suspect eventually we will know, and I do know Dr. Polides can speak to some of the surgical literature on that.
So I'm just going to talk about one surgical case, but a 19-year-old male patient with KT has some discomfort of knee and hip corresponding to affected areas on imaging. When we initially met him, he did not desire treatment or to wear compression because he was starting college soon, very excited about that, and didn't want to compromise that with these other things. 1 year later, we saw him again, and he had increased pain. At this point, he was sometimes sitting out of activities that he would have otherwise liked to do. We discussed some potential hybrid procedures, and he wanted to think about them and get back to us. 2 years after the initial presentation, he reached out to us wanting to proceed with the procedures. And in this particular situation, there were multiple veins that we thought could be causing the symptoms, including some large veins right where he was having hip pain. So what we did is a hybrid procedure with Dr. Bendel and I. The veins were large, about 2 centimeters, and so we didn't feel that they would be able to be effectively closed down with sclerotherapy or ablation because of how large they were. So we did, under the same anesthesia or same episode of going to sleep, we did, Dr. Bendel filled the affected veins with coils. And then directly after that, we did surgery, and we were able to remove these veins with a small incision with minimal bleeding. And with it being very clear which veins we were supposed to be removing because of the coils. You can see here that it looks like there's the little wires in there. Those are the coils. We also do this with glue sometimes, a special surgical glue, which has really helped us be able to expand our effective surgery for venous malformations or for problematic veins that are part of a larger malformation. It doesn't mean that we're treating the entire malformation or curing in many situations, but it can help a lot with symptom management. This patient was also able to have sclerotherapy at the same time of other affected areas that didn't need surgery. After the initial recovery, he reported a reduction in pain, which has been maintained for now. I think some things to consider from a surgical standpoint, and just, you may wonder. I meet patients, and we meet patients in our clinic who might say, I was told I could never have surgery on this, or I shouldn't have surgery on this. It would be too dangerous. And in many cases it is, but I think two things. One, just like a lot of the other interventions and the medical interventions and the genetics and the interventional radiology, surgery has also come a long way over time. And we have new technologies, better understanding. We're able to collaborate with our colleagues, such as for the hybrid procedures, to make a lot more things an option that maybe wouldn't have been before. And then I think the other probably big question is, who does surgery for vascular malformations? Depending on what the issue is, it might be somebody different. And it's often maybe even multiple surgeons that you could be seeing, an orthopedic surgeon. I can tell you I'm a pediatric surgeon here. That's my job title. But before pediatric surgery, I do adult general surgery, so board certified in both. And I actually worked with Dr. Blavitsky when he was still here shortly before he retired. And that was my first introduction to vascular malformations and to clibal Trinane, which was a really great experience. But I think it's important to be working with surgeons who are familiar with the disease and somehow connected with others, because it has to be multidisciplinary. I think that's really the only way, and maybe not even at their center, but are at least able to be in communication with other providers. Some specific things, I think veins are one of the most common things that I think I intervene on, either alone or together with interventional radiology. Veins that are 2 centimeters or more are a little bit less probably a lot less likely to close down with sort of the interventional radiology procedures. And so even though that's very common now for vein issues, sclerotherapy or ablation, when they're very large, I think it's important to ask about a surgical option, just to avoid the potential of having the procedure, having an outwork, and then needing surgery later. We can do this safely. We can coordinate hybrid procedures oftentimes under the same anesthetic now, and a lot of other centers can too. And so if you're going to need several procedures, I think it's worth it to at least ask if they can potentially be combined to save you sort of the small but real extra risk of each anesthetic. The answer might be no, and there might be very good reasons for why they're not combined, but it's worth the discussion. I think one of the things that comes up for transition of care is there are a lot of things that we consider differently when operating or doing surgery under general anesthesia on adults than children. One example would just be DVT or blood clot prophylaxis. Pretty much every adult getting a surgical procedure under general anesthesia gets a small dose of heparin when they're asleep to try to prevent blood clots, and that's kind of across the board. In pediatrics, we don't do that. The risk of blood clots is so low. And so I have to often remind myself and our team, if it's a patient who is now an adult, even though they might be newly an adult or a young adult, we should be giving this at least something for DVT prophylaxis. And so there's little things like that if you are a young adult or an adult being treated somewhere that might see more children, little things like that kind of need to be remembered to make sure staying safe. I know there's a lot of other considerations for anticoagulation when operating on vascular malformations, but this is just anybody getting surgery issue, and we need to remember about those too. Compression postoperatively is also really important, and it can be hard at any age to find compression that fits. I think it's especially can be challenging in patients with vascular malformations because a lot of times, as I hear from my patients, the off-the-shelf options just don't work well and don't fit, aren't comfortable, cause pain, cause even worse problems. And for children and teenagers who are still growing, it needs to be changed constantly, and that's a problem. Insurance doesn't cover it, can't find anyone to measure it. It's really important after surgery or interventional radiology procedures. It can help a lot to have good compression afterwards. And so that's something I need to remember as a proceduralist. I need to help make sure that my patients have an option for this so that they can have potentially the best outcome. There's just one more thing that I would touch on is this question comes up a lot, from patients and even other medical providers would be patients who are taking sirolimus, immune suppression, impaired wound healing. These are some of the concerns that you might read about or hear about, and we're asked, is it safe to do it on this? I don't think that I couldn't tell you everything for sure, but there is good data to support that there's no increased risk of wound complications or wound healing problems taking sirolimus during a surgery for a vascular malformation. So I certainly do not ask patients to stop it beforehand. And I think anecdotally in the surgical community, there's the thought that at least especially when it comes to lymphatic, we think that it potentially could help to be on sirolimus. And sort of the synergistic treatment. We worry a lot about lymphatic leaks after doing surgery for a lymphatic malformation component of either itself or a larger malformation. And so I guess that would be the only other thing I would add is I don't think that being on a medication such as sirolimus would be a contraindication to having surgery, having to come off of it. And it potentially could even help. So I think, obviously it's individualized between you and your surgeon, but just so that everybody is aware, we kind of think about this and it should be safe.